Welcome to this review on cardiovascular anatomy and physiology as it relates to cardiac myocardial perfusion imaging. So just a review, the heart is a muscular organ. It is located in the mediastinum. It sits towards the left at an angle of 30 to 50 degrees. This is one of the reasons it's a little tricky to get the positioning right if you're doing a MUGA scan or an equilibrium scan. But this is also why we process the heart the way we do and reconstruct it into short axis, vertical long, and horizontal long, rather than transaxial, coronal, and sagittal, because it doesn't lie in the same planes. The pericardium contains the pericardial space, and then there are three layers of the cardiac wall. The epicardium, which is the external part, the myocardium, which is the muscle, and then the endocardium, which is the inner part. The heart has four chambers. The left and right atria, separated by the intraatrial septum, and then the right and left ventricles separated by the interventricular septum. The right side has two valves, the tricuspid valve and the pulmonic valve, and then the left side valves are the bicuspid or the mitral valves and the aortic valve. This is separated in colors. Blue is deoxygenated blood, and then the red is oxygenated for the next two slides. So on the right side of the heart, the deoxygenated blood enters the right atrium from the superior and inferior vena cava. During ventricular diastole, the tricuspid valve opens and blood enters into the right ventricle. During ventricular systole, the pulmonary valve opens and blood enters through the pulmonary artery. Pulmonary artery carries the blood to the lungs, particularly to the alveoli and the capillary beds of the lungs where oxygen exchange occurs. Here the blood becomes oxygenated and then it enters the pulmonary veins, which take it back to the heart. On the left side of the heart, blood will enter from the pulmonary veins into the left atrium. During ventricular diastole, the mitral valve opens, blood enters the left ventricle, and then during ventricular systole, the aortic valve opens and blood will enter the aorta and move on to systemic circulation from there. Perfusion of the heart muscle occurs through the coronary arteries that begin at the base of the aorta. The right coronary artery follows the right posterior sulcus, which is that little indentation right there. And you can see the right coronary artery going back this way. It branches posteriorly towards the apex down here into the posterior descending artery. It supplies the posterior and inferior myocardium, and it also supplies the apex in some patients through this posterior descending artery. The left coronary artery branches into the left anterior descending and the left circumflex. The left anterior descending travels down the anterior of the heart. You can see it right here. It supplies the anterior and the septal walls, and then in most patients it also supplies the apex. So the left coronary artery is extremely important. If you have a proximal blockage in the left anterior descending, that could potentially impact the blood supply to the anterior and septal walls of the heart as well as the apex. The left circumflex artery travels along the sulcus right here at the other side, and this supplies the lateral wall of the left ventricle and the left atria. So which part of the left ventricle does each supply? The right coronary artery, which branches into the posterior descending artery, covers the posterior, inferior, and sometimes the apex. The left coronary artery branches into the LAD and the left circumflex, and then the LAD supplies blood to the anterior septal and usually the apex of the heart, while the left circumflex supplies blood to the lateral wall. This is important because it does help us on SPECT imaging. It helps doctors be able to determine which blood vessel the blockage is likely to be in based on the territory of the heart that's impacted. The problem with that is if it's in the apex, this could be the right coronary or the left anterior descending. Unless it's a significant or proximal blockage, it's pretty difficult to tell which artery is supplying the apex because individual anatomy may be slightly different. The coronary veins will carry deoxygenated blood away from the myocardium, and they will terminate into the coronary sinus. Blood mixes with deoxygenated blood from the inferior vena cava and superior vena cava entering the right atrium. One thing that I want to point out is how microvascularized the heart is. When we look at these diagrams of the heart, it's essentially, you don't see it. It's not in the diagram because it would kind of drown everything out. The myocardium is a muscle that is constantly working. It has to be able to respond to stress, exercise, whatever our body needs. And so it is highly vascularized. We are only covering the main coronary arteries, but I do want to point out that all of these little branches go into microvascularization and capillary beds that essentially cover the entire heart. So if you were to actually look at the microvascularization of the heart, it would almost look like a bush during the winter with no leaves on it, or a sponge or coral even that you may see in the ocean because there's so much blood vessel supply to the entire myocardium. Now, the whole cardiac cycle is the period from the end of one cardiac contraction, which is systole, to the end of the next one. And this constitutes one heartbeat. So in diastole, all chambers are relaxed and the blood flows into the heart. At systole, this is where you have atrial systole, you have ventricular diastole. Basically, the atria are contracted and they're pushing the blood into the ventricles. The next cycle is atrial diastole and ventricular systole. At this point, the atria have relaxed and are filling back up with new blood, while the ventricles are contracting and pushing blood out of the heart. Right side is pushing it to the lungs, and the left side is pushing it systemically. These are some quantitative values that are important for nuclear medicine technologists to understand. The first is stroke volume. That's the volume of blood ejected by either ventricle during ventricular systole. The formula for that is the end diastolic volume minus the end systolic volume. And the normal volume for that is about 80 to 100 milliliters. At stress, it's normal for that to be a little lower because the heart is pumping so fast it doesn't have adequate time to fill. And so the end diastolic volume will not be as high. The next one is cardiac output. This is the volume of blood that the heart pumps per minute. Cardiac output is the stroke volume times the heart rate. And normal volumes for that are about 5 to 6 liters per minute. The next one is end diastolic volume. That's the capacity of the ventricle when it's completely filled at its largest volume. Normal volume is about 150 milliliters. End systolic volume is the residual capacity of the ventricle at the end of contraction. This will be the smallest volume, and that's about 50 milliliters. The ejection fraction could be right ventricular ejection fraction or left ventricular. In the case of nuclear medicine imaging, we usually are looking at the left ventricular ejection fraction. And this is the percentage of blood ejected from the ventricle with each contraction. The formula for that is in diastolic minus in systolic divided by in diastolic times 100. For the left ventricle, it's typically anything greater than 50, and for the right ventricle, it's anything greater than 40. Now the cardiac conduction through the heart, the sinoatrial or SA node, also known as the pacemaker of the heart, the atria will contract, and this initiates about 60 to 100 times per minute. There is a delay to allow the atria to contract while the ventricles are filling. So the atria will be at systole and the ventricles will be at diastole. And then the AV node will trigger the bundle of His. This goes into the right bundle branch and the left bundle branch. Then moving to the Purkinje fibers. These are the terminal fibers of the right and left bundle branch located at the apex of the heart. You can see them right here in the diagram. And this is what causes the ventricles to contract. You can kind of see them throughout the inside wall of the myocardium or the endocardium. So this is demonstrating cardiac conduction on an EKG. To start, you have the P wave. P wave is when the atria depolarizes. It's filling, it's getting ready to contract. And then the atria will contract at the P wave. And then it'll be a short break while the ventricles are filling and the atria are contracting. This is that space between the P and Q wave. And then you have the Q wave moving to the R complex, and you can see at the R complex, with the Q wave, the conduction is moving through the septum, and then here it's spreading through the Purkinje fibers. That's the R wave. And then as it gets to the R to S, you see the ventricles are starting to contract. Ventricles are fully contracted at the end of the S wave, and you have this little space right here. That's where the ventricles are fully contracted, and then they will start to repolarize, where basically they are relaxing and they're starting to fill back up with blood. You see that at the beginning of the T wave. And then by the end of the T wave, the ventricle are fully relaxed. So is the atria. And then the heart cycle starts back over again. So this is just showing you again, P wave is depolarization of the sinoatrial node and the atrial contraction, which is systole. And then the PQ is that space right here between the end of the P wave and the start of the Q wave. That is where the atria are depolarizing and conduction is happening through the atrioventricular node. With the Q wave, you have some depolarization through region 3, which is right here at the septa. So that's the start of the ventricle contraction, but it's not really contracting yet. That's just the electrical wave moving through the septum. And then the QRS is the ventricular depolarization and the atria repolarization. That's kind of moving through regions 3 and 4 down here. This is where it starts to hit the Purkinje fibers. And then the RS complex is the depolarization through the rest of the ventricles up through here. And then the T wave is that ventricle repolarization. So the ventricles will contract right here, starting with Q through the beginning of the T. If you look at this, the P wave initiates the atrial contraction. By the time you hit the Q, the atria have fully contracted and are starting to relax and fill back up with blood, but the ventricles are starting to contract, and that will continue until you get to the beginning of the T wave, which is where it kind of starts all over again. So as a nuclear medicine technologist, you need to be able to do 12 and 3 lead EKGs. 12 leads are placed for stress testing with cardiac PET or with SPECT imaging, and the 3-lead EKG is placed for gating purposes for imaging. There are 2 primary uses for it. The first one is monitoring the patient's cardiac status during stress testing. That's where we do the 12 lead. And then the other purpose is a 3-lead, which is used for gating for the images. So this is where you place them: right arm, right leg, and left leg. And then V1 through V6 kind of follow in a line here. V1 and V2 should be opposite sides of the sternum, and then V3 and V4 kind of follow right below it, and 5 and 6 kind of wrap around laterally. So the other placement is for gating. This is the interface with the gamma camera to trigger the data acquisition. And when we're doing gating, it typically will trigger for starting with the P wave or the R. It'll go R to R complex. And if you don't have a good rhythm, then especially if you don't have recognizable R wave, then it may cause a lot of abnormalities, lost counts, rejected beats with the camera, and that can mess up your image quality. It is important to place them in the right place so you're not getting a lot of interference. So right arm, left arm, and then the grounded one should go right here by the side. There are some newer cameras that require different gating. And so typically that will be on a sticker on the back of the scanner, and you would have some kind of training with that camera, particularly the solid state and multi-pinhole collimator cameras, especially like the one that GE puts out. Those require slightly different EKG placements, but for the most part, this is how it will be for SPECT imaging, and then even for any gating, that's what you would have is right arm, left arm, and then the grounded one will be down below, kind of where the apex of the heart is. And you typically do not want these on bone. The bone can cause some interference and kind of block the signal of the heart. It's just a little denser. Now, on the other cameras, the solid state and multi-pinhole, some of them do suggest you put them on the bone. So follow the manufacturer's recommendations for the machine. The EKG paper will move at 25 millimeters per second. It does move fairly quickly. One small box equals 0.04 seconds. One larger box, which you see kind of outlined here, it's 5 by 5. That represents 5 millimeters or 0.2 seconds. So not listed here is the R to R interval, but you see this R right here. That's typically what will trigger the gating. And it will take 8 or 16 pictures between R waves. Normal sinus rhythm is about 60 to 100 beats per minute. Typically anything less than 60 or 50 will be considered bradycardia or a slow heart rate, and anything over 100 is typically considered tachycardia or a fast heart rate. And those could be still normal sinus rhythm, but normal brady or normal tachy, where it's a normal sinus rhythm. There's nothing crazy happening with any of the depolarizations or electrical conduction. It just happens to be faster or slower. Normal sinus rhythm, though, will be between 60 and 80. You'll see identical P waves. The P to R interval will be about 0.12 to 0.2 seconds, and it will be consistent. The QRS complex will be no longer than 0.12. So how spread out this QRX complex is, it is considered for cardiac health and EKG. So you want to make sure that it's nice and close together. The ST segment should be flat. That's the space right here between the S and the start of the T wave. That should be flat, and it should be at about the same level as what it was on, before the heartbeat and for the P wave. It should stay about the same. And the R to R interval will be regular. So R to R up here will be about the same time between each one, and it doesn't vary more than 0.12 seconds between QRS complexes. Sinus bradycardia is less than 60 beats per minute. Other than the rate being too slow, sinus bradycardia does not differ from normal sinus rhythm. Sinus tachycardia, other than being fast, does not differ from normal sinus rhythm. Sinus arrhythmia is recognized by irregular spacing of the QRX complexes. You'll notice these R to R intervals, some of them are closer together, some of them are farther apart. This is marked by whenever the R to R interval will vary by more than 0.12 seconds. If you're imaging a patient and you're gating them, if they have this arrhythmia, then it's going to end up rejecting some beats because it will be hard for that camera to track when to take images. It's going to take a picture either 8 or 16 times between these R to R complexes, but if they're not consistently spaced apart, then it times that, and it could end up in rejecting some beats of the heart and only accepting some of the data. This will result in noisy images, especially on SPECT, because it will lead to rejected counts and rejected beats. This is a unifocal PVC. This is unique and bizarre QRS complex, which is much wider than normal, and there's no P wave preceding them. What happens with a PVC, that stands for pre-ventricular contraction, and essentially the ventricle is contracting before it's time for it to do that, and it will contract before the atria has contracted. It's almost like a spasm in the left ventricle or the ventricle of the heart. This will mess up the gating. Now, if there is 2 of them coupled together, that's called bigeminy. And if there are 3 of them coupled together, then that's called trigeminy. And you would see where you have a couple PVCs like that in a row, and then it goes back to normal sinus rhythm for a while, and then you may see 1 or 2. That's bigeminy or trigeminy, depending on how many you have. And then when it's like this, it's just called a unifocal PVC. That will mess up the gating. If you just have one like that and it goes right back to normal sinus rhythm, then your camera will just reject that beat. If you have bigeminy or trigeminy though, and you're getting a lot of PVCs on the patient, then that of course will mess up the gating and you could end up with more rejected beats. Atrial fibrillation, the atria will quiver. It's almost like a spasm in the atrium. It doesn't have a coordinated contraction. When this happens, there are no true P waves. The ventricular rate may be irregular and result in an abnormal R to R interval. If this happens and you have an abnormal R to R interval, that will interfere with the gating because it measures it on the R intervals. If you look very closely here, you see there's a very large space between these R waves, and then there's close together. Remember, anytime that it differs more than 0.12, that's considered abnormal. But anything like that that's not consistent will interfere with the gating on the camera. Atrial flutter is marked by normal P wave that's absent and replaced by 2 or more regular sawtooth patterns, like waves called flutter. And so you'll see it almost looks like wave or sawtooth, and you'll have a couple different exaggerated P waves before you get to a QRS complex. If the R waves are still regular, that will not interfere with gating. That is an arrhythmia. Ventricular tachycardia results in ranges of 140 to 220 or more beats per minute. and you'll have a run of 3 or more PVCs in a row. When this happens, the heart is beating so fast that the ventricle is contracting before the atria has a chance to really push blood into it and fill it up. So this is recognized as a series of wide, bizarre QRS complexes that have no preceding P wave. Ventricular fibrillation is defined as erratic quivering of the ventricles. There is no CO present, and the ventricular fibrillation shows grossly irregular fluctuations with a zigzag pattern. When this occurs, this is usually pretty something that you need to pay attention to. You may see it during stress testing sometimes if they're on the treadmill. The heart rate will be registered at 300 to 600 beats per minute. This is not really beating that often, but what's happening is the ventricles essentially spasming. And this can be a sign that the patient may be getting ready to code or have some serious cardiac event. So typically if somebody goes into VFib, is what it's called, then the treadmill would stop immediately and you would try to bring the patient's heart rate down. It may be a good idea to get the crash cart or for someone to stand by for that because essentially what is happening there is the muscle is spasming and it could just stop and then start back up again, or it could just stop. And it could calm down and go back to normal with cessation of exercise. So it's usually a sign that there's something more serious happening within the heart. And asystole is a flat line. So VFib will often lead to asystole when it starts spasming, at least temporarily. That's why it's a good idea to go ahead and stop and have someone close by that can help. But asystole is absent rhythm. There is no electrical conduction through the heart. There's no rhythm. You may see asystole, what looks like asystole, just if a lead pops off and it stops measuring. But true asystole means that the heart is not beating. ST depression is something, and elevation are something that really need to watch for in nuclear medicine when we're stress testing. The ST segment depression may indicate myocardial ischemia. If you have somebody that is symptomatic and they have ST segment depressions during any portion of their stress testing when they're hooked to an EKG, symptomatic or not, but if they have ST segment depressions, they should usually probably go for a heart cath or at least more follow-up from their doctor. And so this is essentially what that looks like if you have ST depression. It's down here at the end. That baseline falls below what it should be. Doesn't really recover after the S and come back to a baseline. So that the ST portion is depressed or below the baseline. So this is usually a sign of reversible ischemia, but it is a sign of ischemia, and a lot of times doctors will look at that compared to the images and try to figure out where the ischemia might be. Now, ST segment elevation may indicate a myocardial infarction, which is not reversible. Now, if this is a new onset, that's not great, but if usually when you see this, it is somebody who has had a myocardial infarction in the past and their EKG just may not be back to normal. But if it's elevated, that is a sign that there may be a past myocardial infarction. And that's it. I hope you enjoyed this quick refresher on cardiac physiology and anatomy and some EKG rhythms that are of interest to us in nuclear medicine. Thanks for watching.